Okay, now coming towards the CVS from pediatrics, and we will discuss the topic tetralogy of Fallot in this video. So, we are having a scenario that there is a 3 years old girl brought to OPD with the history of frequent attacks of apnea and cyanosis while playing or running. During this attack, she sits down on floor in squatting position, and on examination, she is malnourished and central cyanosis and clubbing of nails is present. She does not show any signs of respiratory distress or congestive cardiac failure. So, what is the diagnosis, the findings on echo, and the management of cyanotic spills and surgical treatment? So, here we are having the clinical features of frequent attacks of apnea and cyanosis while playing or running. During this attack, she sits down on floor in squatting position and she is malnourished and having central cyanosis and clubbing. She does not show any signs of respiratory distress or congestive cardiac failure. So, this is the tetralogy of Fallot, and the findings on ECG are right axis deviation plus right ventricular hypertrophy, that is large current flow from ventricle. So the treatment of the cyanotic spills and the finding on echo will be right ventricular hypertrophy, pulmonary stenosis, ventricular septal defect, and overriding of the aorta. And the treatment of the cyanotic spill is that acute onset of the hyperapnea and restlessness, increased cyanosis, so gasping occur and syncope occur, increase in ventricular obstruction with further right to left shunting. This is cyanotic spills, and the treatment is oxygen inhalation and placing child in the knee chest position to increase the systemic vascular resistance and to diminish the right to left shunt. Morphine sulfate, that is 0.1 mg per kg by parenteral route, is given to decrease the anxiety and to prevent the sympathetic overdrive, and to correct the acidosis, intravenous sodium bicarbonate may be given. Beta receptor blocking agents, for example, propranolol in a dose of 0.0 to 0.2 mg per kg slowly intravenously is given to decrease the muscular spasm of infundibulum. Cyanotic spills can be prevented by propranolol 1 mg per kg orally even 4 hours until total correction is done. The surgical treatment for the tetralogy of Fallot is palliative surgery and corrective surgery. In palliative surgery, a temporary increase in pulmonary blood flow can be obtained by creation of a systemic artery to pulmonary artery shunt and Blalock tossing shunt. In this, the right subclavian to pulmonary artery anastomosis is done. In Waterston shunt, ascending aorta and right pulmonary artery anastomosis is done. And in Portson shunt is created between the descending aorta and left pulmonary artery. Corrective surgery is done, that is, it consists of closing the VSD, in resecting the right ventricular outflow obstruction, and if necessary, enlarging area with the page. The timing of total correction ranges from 3 months to 2 years depending upon the expertise available. So this was the scenario of the tetralogy of Fallot, and these are the clinical features. There is the frequent attacks of apnea and cyanosis, and the patient sits in squatting position, and the patient is malnourished and centrally cyanosed, and clubbing is present, and there is respiratory distress and congestive cardiac failure. So the diagnosis is the tetralogy of Fallot, and these are the findings on ECG. That is the right axis deviation plus right ventricular hypertrophy. And then the treatment of the cyanotic spill is here. The cyanotic spills are the acute onset of hyperapnea and restlessness, which increase the cyanosis, and gasping and syncope occur, that is the increase in ventricular obstruction with further right to left shunting. These are the treatment options, that is oxygen inhalation and placing the child in knee chest position to increase the systemic vascular resistance, and morphine sulfate is given, and to correct the acidosis, intravenous sodium bicarbonates are given, and beta receptor blocking agents are given, for example propranolol in a dose of 0.1 to 0.2 mg per kg. These are the surgical interventions, that is a palliative surgery and the corrective surgery. So in the palliative surgery, a temporary increase in pulmonary blood flow can be obtained by creating a systemic artery to pulmonary artery shunt, and these are the types of shunt, that is Blalock tossing shunt, Waterston shunt, and Potts shunt. Corrective surgery is done. It consists of closing the VSD, in resecting the right ventricular outflow obstruction, and if necessary, enlarging aorta area with the page, and the timing of total correction ranges from 3 months to 2 years depending upon the expertise available. Another scenario is that there is a 2 years old girl who is brought to OPD with history of frequent attacks of cyanosis while playing and running. During attacks, she sits down on floor in squatting position, and she is underweight and has central cyanosis and clubbing and pensystolic murmur on the auscultation. Here are the same features as we have discussed above, that the patient is having cyanosis, and while playing or running, she sits in squatting position, and also she is having the central cyanosis and clubbing of the nails, and she is having pensystolic murmur on the auscultation. So all these are the clinical features of the tetralogy of Fallot. So the findings on the X-ray will be there will be slight cardiomegaly, and there will be pulmonary vascularity, and it may be increased or normal. And the narrow produced by anterior posterior arrangement of the great arteries give appearance of the narrow pedicle, and heart shape looks like an egg placed on its side. These are the findings on the X-rays in the case of the tetralogy of Fallot, that is slightly cardiomegaly. And narrow base produced by anterior posterior arrangement of the great arteries give appearance of the narrow pedicle, and heart shape looks like an egg placed on its side. Pulmonary vascularity may be increased or normal. The medical treatment for tetralogy of Fallot is that maintain adequate hydration to avoid the hemoconcentration and possible thrombotic episodes, and temperature maintenance is done to limit the oxygen consumption. Blood glucose levels should be monitored to prevent the hypoglycemia. Hemoglobin and hematocrit should be maintained within the normal range. Give iron supplements to improve exercise tolerance. Bacterial endocarditis prophylaxis that is necessary. Oral hygiene must be maintained. Partial exchange transfusion or phlebotomy for polycythemia may be required. Antibiotics and drainage to the abscess, and to prevent growth retardation, correct the defect early and increase caloric intake, and counseling is necessary for the psychosocial problems. Okay, these were all the important points about the tetralogy of Fallot. Okay. Now here we are having another scenario. In the past scenario, we have discussed the findings on the X-ray that there will be cardiomegaly, and narrow base produced by anterior posterior arrangement of the great arteries give appearance of the narrow pedicle, and heart shape looks like an egg placed on its sides, and the pulmonary vascularity may be increased. The medical treatment is adequate hydration, temperature maintenance, glucose maintenance, hemoglobin and hematocrit, iron supplements, bacterial endocarditis prophylaxis, partial exchange transfusion, antibiotics and drainage, and counseling. Now another scenario is that there is a 2-year-old presented with history of recurrent attacks of restlessness and cyanosis, occasionally followed by syncope. Since few months ago, on examination, her height and weight are below third centile, and she has central cyanosis and digital clubbing. On auscultation, she has ejection systolic murmur at the left sternal edge. These are the clinical features, that is recurrent attack and restlessness and cyanosis, followed by syncope, and also she is malnourished, that is height and weight is below third centile, and she is having central cyanosis and clubbing, and there is a systolic murmur. So the investigations for tetralogy of Fallot are blood counts, that is hemoglobin, hematocrit and RBCs count are usually mildly to markedly elevated depending upon the degree of the arterial oxygen saturation. On the chest X-ray, heart size is normal. Apex is lifted and concavity is noted in pulmonary segment, giving the heart appearance of a boot-shaped heart. Pulmonary vascular markings are diminished. Aortic arc is right-sided in 25% of cases. The treatment of the patient we have discussed already above. The complications of the tetralogy of Fallot are cerebrovascular accident. In children younger than 2 years of age, this complication almost invariably is secondary to hyperexemia and anemia rather than polycythemia, sludging and in situ thrombosis. The brain abscess presents with fever, headaches, vomiting, and cranial nerve pulses with raised intracranial pressure or other localizing signs mainly seen in children more than 2 years of age. It is due to the right to left shunting. Bacterial endocarditis is due to the right to left shunt. Polycythemia is due to persistent hypoxia. Relative anemia is due to nutritional deficiency. Failure to thrive is due to increased oxygen consumption and decreased nutritional intake. And psychosocial problems is due to chronic disease and multiple hospitalization. So in this section, what we discussed the investigation options that are done for the tetralogy of Fallot. These are blood counts and chest x-rays, and the treatment of patient is already discussed. In this specific section, we discuss the complications, which are cerebrovascular accidents and brain abscesses and bacterial endocarditis, polycythemia, relative anemia, failure to thrive, and psychosocial problems. So what are the main clinical features of the tetralogy of Fallot? That there will be the signs of syncope and central cyanosis and clubbing. Central cyanosis and clubbing and the attacks while playing, and there will be also a systolic murmur present. So these will be the findings on the X-rays, that the cardiomegaly will be present. Okay, these are the cyanotic spills, that is acute onset of hyperapnea and restlessness, increased cyanosis, gasping, and syncope, increase in ventricular obstruction with further right to left shunt, and these are the surgical treatment. These are the types of shunts that are used, and these are the findings on X-ray, that is cardiomegaly and egg placed on her side, and the pulmonary vascularity may be increased. The medical treatment is to maintain adequate hydration and temperature, blood glucose levels and hemoglobin, iron supplements, partial exchange antibiotics, and counseling is done. And these are the investigation options, that is blood count, chest X-ray, and the complications are cerebrovascular accidents, brain abscess, bacterial endocarditis, polycythemia, relative anemia, failure to thrive, and psychosocial problems. In the next section, we will discuss the transposition of great arteries. Thanks for watching.